Our next speaker, Dr. Karthik Narayanan sir, is a pediatric intensivist with more than 11 years experience. He has graduated from PSD Coimbatore, completed his MD and DM in pediatric critical care from PGI Chandigarh. He is the first pediatric critical care consultant from Tamil Nadu. At present, he is holding pediatric critical care intensivist at Rainbow Children's Hospital. As medicine is an overgrowing science, updating our knowledge is equally important. I am profusely elated to welcome Dr. Karthik Narayanan sir for the next speech on recent updates in the management of sepsis.
Thank you. I thank the organizing team in ICH for giving this opportunity. So, sepsis, septic shock or pediatric sepsis, they keep on getting updated no matter how much times we read. So when I go through the presentation, you will understand what are the difference which has happened so rapidly over a short period of time. So this was given by Alvin Toffler. He is a futurist, he is a big novelist, and what he said was the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn and relearn. And that is what we do every time in medicine, and that is how the medicine has grown. So again, in sepsis also, whatever you know these things, you have been practicing these things, but after this presentation, you try to unlearn them and then you try to relearn. So we go to a case. So it's a 1-year-old child with fever for 5 days, cough for 4 days, breathing difficulty for 1 day, poor feeding lethargy, not passed urine. Every other history is normal. There's no history of rash. And on examination in our emergency, you find that the child is having tachypnea with increased efforts, differential air entry and significant crackles on the right side. There is significant tachycardia with cold peripheries and CFT is prolonged, capillary filling time. The BP is 90/40. There is a mild letharginess and decrease in sensorium. Otherwise, the activity is normal and symmetrical. The child is having fever. So, you are posted in a district hospital. Now you are in ICH. Eventually, everybody will be posted in different settings and we don't know where we are going to go about. So suppose if you are posted in a district hospital with no pediatric ICU backup like what you have here. So that is when the challenge arises in management of sepsis. So how will you manage this case? Is this sepsis or septic shock? How many of you say yes? It's a very simple question. I see very less hands rising up. Everybody are final year PGs, right? Is this sepsis or septic shock? Septic shock. Okay. So how will you define a sepsis or septic shock? So the point starts right from there. How are you going to define sepsis? Why can't it just be a child with SIRS and not septic shock? The peripheries can be cold due to temperature, like environmental exposure. Child's blood pressure is normal. So how do you define sepsis or septic shock? So for that, recently in the past 2 years itself, there are 2 different guidelines which were published. In 2017, American College of Critical Care Medicine and PALS gave a detailed recommendation on how to manage sepsis and septic shock in children. And within 2 years, again Surviving Sepsis campaign, they gave another guidelines in management of pediatric sepsis and septic shock. So both are pediatric specific. Usually Surviving Sepsis campaign, they don't give pediatric specific guidelines for septic and septic shock. And what is the necessity? What has changed in the past 2 years that they had released 2 guidelines? So the PALS 2017, they focused predominantly on bundle approach and how to manage a patient. And it comprised of recognition of sepsis, which is the first part. That's why I said, no, whether it is sepsis or septic shock, that itself is very important in your further management. So the most important is recognition of sepsis or septic shock. Then comes your resuscitation, stabilization, and performance, like how well you are performing in managing sepsis. So this is your septic shock trigger identification tool, which simply means, like, it's too complex to look at it. It simply means like you have a suspected infection which features of SIRS, meaning unexplained tachycardia, unexplained tachypnea, hypothermia or hypothermia, along with fever, and you have what to say, if you have a TLC count, if you find that there is excessive leukocytosis or leukopenia, then you have SIRS. But if you have a focus of infection, you term it as sepsis. So this is what they had said. But how will you know when the child is coming to you? Tachycardia, tachypnea will be there in every child. Focus of infection is plus minus. Fever is a subtle sign. It can be even a viral infection with tachycardia and tachypnea. So these are the dilemmas that we face day in and day out. That is when they started to bring about this perfusion abnormalities. If you don't have this, do not treat it like a severe sepsis or septic shock. So perfusion abnormalities meaning your CFT change along with mottled or cold extremities or a decrease in urine output or alteration in sensorium, most likely the sensorial alteration, which indicates your CNS perfusion. So if there is excessive irritability or if the child is extremely lethargic along with your cold extremities and you have a prolonged or flash CFT, you think of a sepsis or a septic shock. Whereas this scenario changes in a high risk setting. High risk setting meaning if your child is having any of these like malignancy, a child is a bone marrow transplant candidate, or your child is having any immunodeficiency, your child is on long-term steroids, all these changes might not happen to every child. So in these situations, fever, tachypnea, tachycardia, or any feature of SIRS, any two features of SIRS with fever, you have to consider that this child is in sepsis. And then they gave a timeline based management. Everybody would have seen this chart. How many of you have seen this chart? So everybody would have seen this chart and they would have been managing septic shock like this for most of the time. So there is a timeline, 0 minute they say recognize decreased mental status and perfusion. This is the first sentence as I said. And then they said begin oxygen and IV access. And within 5 minutes you go and start your fluid boluses. Within 15 minutes you complete your fluid boluses if or until there is any rales or crepitations or hepatomegaly, and then you decide whether you have to start on inotrope. Inotrope, if you have dopamine, you give dopamine. If dopamine you are not having, you give epinephrine, and then you titrate your epinephrine or norepinephrine. After 60 minutes you decide whether it is catecholamine resistant shock. So this is the strict guidelines which is being followed for many years together. And 2017 also they suggested the same except for few changes, where here they said it is preferable to use epinephrine as compared to dopamine. It is preferable to titrate epinephrine, and dopamine you use only if epinephrine or norepinephrine is not available. This is the subtle change which was introduced in 2017 in the initial management. And then they classified the septic shock after your epinephrine and norepinephrine doesn't work into normal blood pressure cold shock, low blood pressure cold shock, and low blood pressure warm shock. And they also advocated the use of SeVO2, meaning the central venous oxygenation. And then they decide what inotrope to add and how to go about. So this was a routine guideline for shock management that has been used from way long, and these parameters they didn't change much. This is since 2012, it is the same parameters. So we have got our answers. So based on the previous guidelines, everybody would like to give a fluid bolus, right? Our child is having cold peripheries, excessive tachycardia, there is poor perfusion, the sensorium is poor, and you have identified that the child is in septic shock, and initial response for you is to give a fluid bolus, right? So how much ml will you give? How many of you will give 20 ml per kg? Most of you will give 20 ml per kg. Okay. So anybody would not want to give a fluid bolus for this child? Nobody. Okay. So the recent guidelines says this. So they say like systematic screening of sepsis, you have identified the sepsis. If there is no septic shock, only sepsis is suspected, you do an expedited diagnostic evaluation. So you do workup, you do your TLCs, you do your inflammatory parameters, you take your blood cultures. And if your diagnostic evaluation supports sepsis associated organ function, then you go ahead and do aggressively manage. If at admission itself there is a septic shock, then there is no timeline. The basic difference in the last guideline and the recent surviving sepsis guideline is they have not given a predefined timeline, like within 5 minutes you have to give bolus, within 15 minutes you have to complete your bolus, within 60 minutes you have to finish your inotrope and say it is catecholamine resistant. So these things are not there. Up to 1 hour they are given your timing. In this 1 hour they have just mentioned you obtain access, collect blood culture, start empirical antibiotics, you measure your lactate, administer fluid bolus if shock is present, and this star meaning you need not always administer a fluid bolus, which means like there is no mandatory, like if your child is having shock you have to give only fluid bolus. That I will explain it in the next slide. And vasoactive agent also, like you can start vasoactive agent upfront without giving a fluid trial. So that is why they have mentioned a star. So this is completely different as what is being mentioned in 2017. So why? So here they have defined into 2 healthcare systems in sepsis. Healthcare systems with intensive care backup, like your ICH, where you have pediatric intensive care backup, and healthcare systems without intensive care backup. So what is the basic difference? In healthcare systems with intensive care backup, if there is any abnormal perfusion with or without hypotension, if your BP is normal or BP is abnormal, if signs of fluid overload are absent, you administer 10 to 20. So the mandatory 20 is gone. So you can administer even 10 ml per kg of fluid bolus. And there is no time limit, meaning you can administer the bolus slowly. There is no need to rush with fluid bolus. So you give the fluid bolus even to 20 minutes or up to 30 minutes and you see for the response. Repeat assessment of the hemodynamic response to fluid and consider fluid bolus until shock results or signs of fluid overload develop. So there is no time limit. You can give fluid, but the ultimate aim is to reassess as the fluid is going on. Assess your cardiac function. See, in the initial phase itself, they are coming up to assessment of cardiac function. So initially they said you start epinephrine or norepinephrine based on your cold shock or warm shock. But here they are saying assess a detailed cardiac function. And then you consider epinephrine or norepinephrine if there is myocardial dysfunction or not. So you identify the difference here rather than the previous difference. The previous guideline says even if you have an ICU unit, even if you have the setup, you follow the same algorithm. But here they say you go for specifics. So if you have a good backup, if you have a good ICU unit, go for specifics and then you manage accordingly. But if you don't have the support systems, in healthcare systems where you don't have PICU backups, so what you are going to do? Here they have classified into 2, abnormal perfusion without hypotension and abnormal perfusion with hypotension. If your child is having hypotension, then you administer fluid. If your child is not having hypotension, like in our case, if you see this case in a district hospital without PICU backup, the guidelines says that you can even avoid fluid. You consider starting vasoactive support if available. If you have epinephrine or norepinephrine, you feel that is okay, you start it. Your child is having white pulse pressure, you start vasoactive support, low dose, but you avoid fluid and you start maintenance fluid alone. So this is what the recent guidelines says. Why they say this? Because resource limited settings, we have only few, without PICU backup, only few trials, and most of these recommendations are based upon the FEAST trial, where they found like when you give fluid, there is ultimately no big difference. And eventually they feel like you restrict fluid, or if there is any you start maintenance fluid, monitor hemodynamic closely, and you start an inotrope, but don't give fluids. So this is the difference. Or you transfer the child to a setup with an inotrope or with a vasoactive where they can assess and give fluids later. And what fluid to give? In 2017, they typically said give NS. Crystalloids, NS, normal saline, 0.9% normal saline. But in 2020, they say it is preferable to use balanced crystalloids or buffered crystalloid, meaning everybody might have heard about plasma light. So it is preferable to use plasma light as a fluid bolus as compared to NS rather than 0.9% saline. So this is a gross difference. Even though the recommendation is based on a weak recommendation and a low quality evidence, but the whole panel decided to go for a balanced crystalloid as compared to 0.9% normal saline. So this is a septic shock. Will you give bolus or not? If you are in a district hospital, it is no. If you are in ICH, then it is yes, along with a cardiac monitoring in the initial assessment itself. So is it a cold shock or a warm shock? Yes, this is the previous recommendation where you target MAP based on hypotension. So they say like MAP is mean arterial pressure minus the perfusion pressure is mean arterial minus central venous pressure. So here in newborn you target 55 plus age into 1.5. Infant is again it is the same around 58, and children it is around 65. This is what you target. But if you are in a periphery where you don't have that much of intensive care facilities, the blood pressure cutoffs itself have been changed in the recent guidelines, in which they say that the systolic hypotension in healthcare systems without intensive care is defined as either systolic blood pressure less than 50 in children less than 1 year. Usually we say we take less than 60 systolic blood pressure is hypotensive. So here they say less than 50, and systolic blood pressure less than 60 in 1 to 5 years. So here usually we say 70 plus age into 2 systolic blood pressure, which means for 5 years it is 80. But here they are coming down on the systolic blood pressure to define hypotension, and less than 70 for children more than 5 years. This is in places where you don't have a intensive care or a significant monitoring setup, or presence of 3 WHO criteria like cold extremities, prolonged capillary refill, which is more than 3 seconds, or a weak pulse. Then you define it as a hypotensive shock. So if you have a good pulse, even your systolic blood pressure is 70 in a 5-year-old child, it is not a hypotensive shock if you are working in a periphery. So don't give fluid bolus. This is what the recent guidelines is. So everything is because of harm for fluids. So they are completely shifted. In this guidelines, they don't have any hesitation. In your work, in a place where you have limited resources, they have completely shifted to avoid fluids. Next comes your fluid refractory shock. So here in fluid refractory shock, as I said before, it is between epinephrine and dopamine. If you don't have epinephrine, you can use dopamine. This is what they said. But the recent guidelines says like you use only epinephrine or norepinephrine, do not use dopamine. And they also suggest not using bedside clinical signs in isolation to categorize children like warm or cold shock. Here you can see they typically say give epinephrine for cold shock, give norepinephrine for warm shock. But here in 2020 they say do not use bedside clinical signs. Do not start inotrope based on your, or titrate inotrope based on your bedside clinical signs. So then how to titrate your inotrope? So we suggest using advanced hemodynamic variables in an intensive care setup. So advanced hemodynamic variables include your echocardiography, cardiac output, invasive arterial blood pressure, your SeVO2 or mixed venous oxygen saturation, and if you have, you can do a continuous cardiac output monitoring also. So these are advanced hemodynamic variables where you would be able to calculate your ejection fraction, cardiac output, systemic vascular index, your fluid load, your preload capacity, everything, and then you can titrate your inotropic management. So this is what they suggest if you have. If you don't have, you keep on titrating either epinephrine or norepinephrine in the periphery and try to transfer your patient to the nearby tertiary care center which has PICU facility. So whether the epinephrine and norepinephrine can be initiated in a peripheral line, yes, they can be initiated in a peripheral line, but eventually it has to be changed to a central line. So will you start directly an inotrope? In this case, yes, you can start. IV antibiotics. Next question, whether you have to give a single broad spectrum therapy or multi-drug therapy. So how many of you for this case, what is this case? It's a case of pneumonia, right? Fever, cough, breathlessness, going ahead with septic shock. So how many of you will give single broad spectrum antibiotic therapy? How many of you will give 2 antibiotics? Single, raise your hands. Very good. 2 antibiotics? Okay. So we have predominantly people say single antibiotic. That is actually a good sign. Like we are going towards more of an antibiotic stewardship. That is what the recommendation is also. So you have to have a single broad spectrum antibiotic therapy. So either you can use ceftriaxone, or if it is an hospital acquired, if you are suspecting gram negative, you use broad spectrum coverage like piperacillin, tazobactam or meropenem. So the combination of antibiotic you have to use only when there is a high risk immunocompromised child or in a child where you suspect multiple pathogen. For example, you are suspecting a pathogen where you have to cover both anaerobes as well as gram negatives. Then you can add metronidazole or clindamycin along with your piperacillin tazobactam or other antibiotics. But if you are not suspecting polymicrobial sepsis, go only with a single broad spectrum antibiotic therapy. And source control is mandatory, and you don't have any evidence for this, like you have to control the source. It is a best practice statement. Best practice statement means you need not require an evidence. This has to be done. So don't search for an evidence. Source control, it is mandatory. If you find a source of infection which has to be drained or corrected, you have to do that. Blood culture, it should always be taken before initiating antibiotic therapy. And do not, if that delays your antibiotic therapy more than this stipulated time, then you give antibiotics and then you take the blood culture. But if you can take a blood culture, there is no need to rush for antibiotic therapy, provided you just give within this stipulated time. You have 1 hour of time to administer antibiotics in a septic shock. So you can take a blood culture and then you can administer antibiotic. There is no need to immediately rush with antibiotics. And also if the child with infections, you have 3 hours. So take a blood culture and then you can go ahead with your antibiotic therapy. So single. So will you send workup for all organ functions for all cases with sepsis? How many of you will send? This is again a dilemma, right? Investigations we want to limit, but sometimes we have to do. So in sepsis, should we have to send workup for LFT, RFT, PT, APTT, everything? Raise your hands, how many will send? So it's a mixed group, 50-50. Okay. So what does the guideline say? Now I am coming to hydrocortisone, which is a debated topic. There is no role for hydrocortisone. Previously they said in a catecholamine resistant shock, you consider hydrocortisone because of relative adrenal insufficiency. But now they say there is no role to give any IV hydrocortisone in any case, except when your child is known to have adrenal insufficiency. Then only you are going to use hydrocortisone. So organ, yes, they recommend to do an evaluation of organ functions for any child with sepsis. Why? For example, this child is stabilized with norepinephrine of 0.1. You started on IV ceftriaxone, chest x-ray is suggestive of pneumonia with syn pneumonic effusion, and you started on high flow nasal cannula. Your urine output is fine. When you do the investigations, you find your hemoglobin of 8, total count 20,000. It's just neutrophilic predominant. Platelet is 35,000. Your INR is 2, SGOT, PT are deranged, urea is 74, creat is 1.1, urine routine is showing no pus cells, LDH is elevated, D-dimer is negative, lactate is 2.6. So you have done all the functions. So what are you going to do with it in a child with septic shock? So here comes multiple dilemmas. So should you have to transfuse for hemoglobin of 8? Should you have to give platelet transfusion prophylactically for a platelet count of 35,000? Or FFP for INR of 2, and you wish to start PD or CRRT. So these are multiple things which you have to decide. Why we are recommending doing organ functions for all sepsis is whether we have to decide whether to give any adjunctive therapies or whether we have to decide on any adequate support of this child is necessary, or whether this child is going ahead into a multi-organ dysfunction syndrome. So that is why we have to evaluate for multiple organ functions in any case with sepsis. So should we transfuse this child with PRBC, platelet or FFP? How many of you will give platelet transfusion? Platelet is 35,000. Nobody. FFP? No. PRBC, hemoglobin 8, child is in shock, but corrected with norepinephrine. Good. So the recommendation is we suggest against transfusion of PRBCs. Even if the hemoglobin is more than 7, or hemoglobin even if it is less than 7, if the child is having the shock corrected, if a child is not requiring any further inotropic escalation, do not transfuse PRBC. Just wait. The recommendation changes if your child is having ARDS. If a child is having ARDS, then you have to give transfusion if your hemoglobin is less than 7 mandatorily. But if a child is not having ARDS, if a shock is corrected, you can wait. And if your hemodynamics are not stabilized, then you go with your other parameters. Your mixed venous oxygen saturation is less than 70%, then you have to increase your oxygen carrying capacity, so you maintain your hemoglobin more than 7. But if your shock is corrected, even if your hemoglobin is 6 or 5.5, don't transfuse. Just wait. Plasma and platelets, there is no prophylactic transfusion. Even if your platelet count is 10,000, the reset guideline says do not transfuse platelet unless the patient bleeds. So previously for any sepsis we transfuse less than 50,000 or 20,000. So if here they say there is no particular platelet counts cutoff, if a child is bleeding, there is thrombocytopenia, transfuse. If a child is not bleeding, don't transfuse either platelet or FFP. Immunoglobulins, many people are now started using in multiple places, but there is no recommendation to use IVIG routinely, except in these conditions. When you know your child is already immunocompromised, like a primary immunodeficiency disease, if your child is suffering from toxic shock syndrome where IVIG is known to be beneficial, and if there is any necrotizing fasciitis, then you give IVIG, otherwise there is no role for IVIG. Extracorporeal therapies, plasma exchange. So when will you actually do plasma exchange? When there is evidence of TAM-off. What is TAM-off? Thrombocytopenia associated multi-organ failure. Where there will be thrombocytopenia, there will be progressing multi-organ failure. Whereas when you do a repeat count, organ functions, there will be worsening of organ functions. But there won't be DIC. There should not be DIC, meaning your D dimer should be negative. Okay? There should not be any frank bleeds, but your thrombocytopenia should be new onset. The peripheral smear should be showing evidence of hemolysis, presence of schistocytes, or evidence of microangiopathy, if you have to say. So look for evidence of microangiopathy, new onset thrombocytopenia, no DIC. That is when you have to consider plasma exchange. That is known to be beneficial. But plasma exchange routinely is not beneficial for any child with severe sepsis or severe multi-organ dysfunction syndrome. CRRT, SLED and PD. So again, this is one thing which many units do. In fact, I also do, but that is being done to prevent fluid overload. All we want to do CRRT or SLED or PD is to prevent fluid overload, because we all know that fluid overload is an independent contributor of mortality in any patient in PICU. So if you are not able to maintain your fluid balance with fluid restriction or your diuretic challenge test, then you have to consider either CRRT or PD or SLED therapies. Otherwise, you need not consider. If you are able to achieve your fluid balance with fluid restriction or diuretic challenge test, there is no role for CRRT or PD. ECMO, if there is severe ARDS or refractory septic shock, you can consider ECMO. Thank you.